Project Lazarus, we've been around in Wilkes County for, a number of years, kind of officially getting going in about 2007. But I first started to address this issue back in 2004 as part of hospice when I began to see issues with opioid pain relievers and medications in the home. But through all of that, having no experience as a preventionist or somebody who was experienced in counseling addiction or any of that, it just kind of fell into that deep, dark hole of asking questions and then attempting to find answers. And some of those answers I want to go over with you today, because as we developed, we wanted to make sure that if we were attempting to reduce the overdose deaths from prescription medications in Wilkes County or any community, we want to make sure that we don't create problems by trying to fix problems. And when we start talking about overdose, it's immediately, well, if we didn't have the medication out there, we wouldn't have the problem. But what about the individual who needs the medication and the care? So we had a balanced approach of addressing it with preventing the overdoses, but making sure that we were presenting responsible pain management, but then also making sure that we have substance use services and support networks within our communities for those individuals who have developed substance use disorder, the disease of addiction, and the like. That's what builds a community, and that's what the response is, and we have to have that balanced approach both at the community, state, and national level. But as I learned about overdose, because when I first heard about it, my mind immediately goes to Hollywood. That was my only experience, is what was in the movies. There was no other personal experience in my life, but then I realized, first of all, it's classified as accidental. It shows up as statistics in the Division of Public Health in the injury section, because it's in overdoses that are not intended, not planned. It's an individual that was not attempting to commit suicide. They just took something, mixed something, ingested something that unfortunately created an overdose. And over time, we've had to accumulate data in order to really know exactly what is happening in our community, specifically in Wilkes. And in attempting to do that, early on, that was very, very difficult, because data for anybody that's involved in that is housed in different agencies, different organizations at the state level. Very difficult to corral that and bring it all together, but thankfully now in North Carolina we have been able to do that. But the person that I am, numbers are great, but give me a face, give me a life, give me a person. I've got to be able to see exactly, what's the history, what was, I know the outcome was a death, unfortunately, but what brought that about? And as we began to study those individuals and those circumstances here in Wilkes, we realized that the who, what, when, where, why, and how helps us to prevent the next person, and the next person, and the next person. And as we did that, we literally have patients who simply misused medication that was appropriately prescribed for the right diagnosis, but unfortunately they did something incorrect with that medication. They either had more pain, took more pills, or the prescriber of one medication did not know about the prescription that another doctor was writing. And then the mixture of those creates, an overdose. We are addressing those, but understand that simply every time we talk about overdose, oh, it's just some or one of those people over there, or some druggie, and I hate all of those words, but and that's why I say it that way, because an overdose does not mean that somebody was actually trying to do and abuse and do something wrong. But then we have family and friends who share to self-medicate. Save the copay, save the doctor visit, save the ED visit. Mom's got some meds in the cabinet, and those meds are for pain. Johnny has some pain, so Johnny helps himself to mom's meds, and unfortunately, Johnny dies. That has happened here, and it's happened in many communities in North Carolina. That is a simple, everyday kind of practice that we, in families and in communities, that has become the norm. And that's something why we address this from a public health perspective. We've got to turn that time, we have to turn that behavior, we have to turn that perception that if a doctor wrote it and it's in the house, it's all okay, no matter who takes it. We can't do that anymore. But, again, that's common practice. Now we have accidental ingestion going on. I will share some of the numbers around the country of how much is actually dispensed to our communities in our states. And then we have a huge increase. I think in 2012 it was like 3,300 emergency department visits because of toddlers who accidentally ingested medication in the home. Unfortunately, some of those toddlers did not live. So again, it's another issue in how we have to address that. And then of course the recreational user. That's somebody, I had a rough week, I'm going to go out, have a good time on the town this weekend. I'm going to go out with some friends and, have a drink or two. Unfortunately, too, maybe a little marijuana, pretty much common in many of our communities. But now somebody's got pills in their pocket. Now somebody is saying, well, here's a little bit of this. This will really help you relax. And it's the last thing they ever take. Not realizing that, again, what one pill for somebody is great, for somebody else can mean death. There's that much potency in the medication. And then we have substance use disorder, somebody who has developed an addiction scenario, somebody who has the disease of addiction or has become totally dependent on that. We have worked with individuals taking 16 pills a day, 25 pills a day. I met a young lady, thankfully in recovery, she was up to 45 pills a day. Now understand, probably 5 of those and I would not see the light of day again. But understand, when we're talking about addiction and say the pain medications, the pain relievers, you need more and more and more and more to have it anywhere even close to the original effect that you were attempting to. Somebody on 45 pills a day, they are doing that for one reason: to feel as normal as possible, not to fall into withdrawal and become dosing. But you can't keep that up forever. It could be 45 one day, 10 the next, 15 the next, 20 the next, then 45. You are right on that precipice of an overdose. So as a community, how do we reach everybody? Because this is everybody at every age. I can't tell you, well, it's just this population group or this population group. It is across the board. It is not subject to age. It is not subject to race. It is not subject to economics. It's across the board, which means we have to reach everybody at every age level. When you say every age level, when I have a 5-year-old tell their kindergarten teacher that they really like their mommy when their mommy takes her happy pill, we have a problem. Because the 5-year-old has just learned that happiness comes from a pill. And if you're not happy, people don't like you because I live and like my mommy. Understand the concept of what we're talking about and how people perceive medication and what it can be used for. And again, from a public health perspective, how do we address that to overturn that? Changes in tolerance bring about an overdose. Somebody can be, taking it for a while, then off for a while, and then unfortunately, overdose. Somebody coming out of prison or jail who was using before and arrested, went through withdrawal while they were in there, and then they get released. Unfortunately, what do they want to do when they get out? Without any help and support, they're going to go right back to what they were doing, not realizing that those 380 milligrams of oxycodone that they were kind of using for the wrong reasons before becomes their death sentence. In North Carolina, somebody being released from prison or jail is 12% more likely to die from an overdose than the general public. We have to get to them before they're released, so that they at least have the education and the awareness, so that they can make hopefully the right decision. And then other individuals who take something with something, not realizing that. We actually had individuals who were taking their pain relief medication, and that prescriber did not know that they were taking their benzodiazepine for their anti-anxiety situation. But as they did that and put the two together, they unfortunately died from an overdose. They didn't want to tell the doc that they were on an anti-anxiety medication because of what people think. That's a stigma problem. Because again, everybody's different, but we have to communicate so that everybody's aware of that, and there are now mechanisms to do that. But about the biological factors, somebody could be taking all the right medication, but if they have that sleep apnea or heavy smoking or emphysema or COPD, they are more at risk from a pain relief opioid medication for an overdose than a regular person because of that. We actually had one situation where a man, husband and wife, the man was on pain medication, rightfully so, chronic pain condition, had been on it for years, and he got a horrible bronchitis flu situation, which means what? Your breathing is diminished, your lungs sort of fill with fluid. They put him on erythromycin in order to, take care of the infection. While the erythromycin, the antibiotic, slows down the metabolism, your lungs are already difficult breathing, your opioid suppresses breathing in itself, the combination of all of those put that person into an overdose. Thankfully, his wife recognized it, rescued him, and he survived. But understand, if the person, the patient, the family, the caregiver does not know that information, then they're at risk. So we have to make sure that the whole chain of care, from the prescriber to the pharmacist to the person to the family and caregiver, that everybody has that appropriate information. Because the CDC has shown us in this pyramid that for every one overdose that we're talking about, one person, there are that many, 15 who are getting into treatment, 26 who have an emergency department visit, another 115 who are abusing or are dependent, and then 733 non-medical users. We're talking about 800 to 1,000 individuals per every one overdose that could be. Again, from a community perspective, and this is why we need you, we all need you, how do we reach those individuals? Because those 733 non-medical users are our families and friends in our neighborhoods. It is not the back alley, it is not down the street, it is not in some other state, it's right here in Wilkes County. People not realizing they're doing something that they shouldn't be doing, but out of habit and out of consistency of what's been done in the past, that's what they do, and that was over $4 million of healthcare costs just in that year because of that. So understand who has to be reached. Everybody has to be reached in this. Because every day in the United States, about 46 people die from an overdose from the prescription medication. In 2012, in the United States, we dispensed 259 million prescriptions. That was not just written, that was actually dispensed from pharmacies. 259 million prescriptions are dispensed into our communities, which means there is enough that's already out there for every adult in the United States to have a 30-day supply today. That's controlled substances, primarily opiates, yes. That's primarily pain relievers are what I'm talking about, even though the benzodiazepines are in there. Understand when we're talking about an overdose, and thanks for the question, because about 70% of the overdoses is not just one drug. And the number one other category is usually a pain reliever and a benzodiazepine, a behavioral health medication. And then we get into your others, your cocaine, your heroin, something else, alcohol mixed with that. So, and also understand, unfortunately, where we live in the southern states, that's the highest prescribed states in the country, for whatever reason that may be. I will not tell you we should stop writing prescriptions because there are people that need them. But once a doctor writes it, once a pharmacy fills it, and it walks out that pharmacy door, it's out of their control. Where is it then? It's in our community. How do we handle that? How do we operate with that? How do we dispose of it? And those are the things that we'll talk about. This is our lovely state. 2001, going back to, the darker communities are those that had the higher overdose rates. And I can tell you, when I started to ask questions in 2004, the thought in Raleigh was, it's just those people on the other side of 77. I hate to say that, but that was what I heard. Our own director for the National Institute of Drug Abuse at the federal level said, oh, well, Appalachian, their streets are paved with Oxycontin. That was her comment. All right, and then not to say that we haven't had issues, and a lot of this was sort of birthed, if you want to call it, in the Appalachian region, but guess what? Over the years, this is what has occurred in the state of North Carolina, going through, and here to 2011. We have a statewide problem, we have a national problem, and we are in legal epidemic status because of that problem. And these are pain relievers I'm talking about. I'm not talking about heroin. That's a whole separate issue that we're talking about. So realize every state, every community has to be reached, with this issue. So what happened in Wilkes County? We had nothing to start with here. I mean, it was myself, it was Sue Alberts, it was the other health department folks. We just sort of sat down and said, okay, what do we do? And we realized, well, guess what? Wilkes is our house, is it not? We got to fix our house. Nobody's going to do it for us. I couldn't find help from Raleigh. I couldn't find help in Washington because at that time, people were saying, what problem? Because they weren't aware of it. But understand, and you've heard me say this before, in 2007, Wilkes County, North Carolina had the third worst overdose rate from prescription medications in the entire country. Every county, every state, Wilkes was number 3. We're no longer there. We're no longer even on that radar. But again, we're talking 10 years later to finally be where we need to be with that. But as we developed this is what we realized we had to do. And you have a trifold in front of you that has this information in there. And this is a very simplistic, but this is not a complete model that we're talking about as far as hub and spokes of public health model. There's many branches that go off of this, and that's where we need to target to make sure that at every level and every population group and every agency, organization, and person in the county, we need to do that. Well, I learned last week about collective impact from our health foundation. Somebody put a name to what we did in Wilkes 10 years ago, which I wasn't even aware of until last week. But large-scale social change requires broad cross-sector coordination, yet the social sector remains focused on the isolated intervention of individual organizations. That means, why are you sitting at a table that has a label on your table? We're not labeling you, but that's what you do. So we want to make sure that in what you do, you have best practice to address this issue with the population that you serve. We don't have to cross each other, we just need to do it with what we do every single day. And that's part of what we're doing today. So public awareness is key. If I found a problem in Wilkes County in 2004, and I started to ask questions, I found our sheriff's office said, yes, we have a problem. Our emergency department said, yes, we have a problem. Our health department looked at the data and said, yes, we have a problem. Anybody else was like, what problem? You know, that was the awareness factor. So we have to build that. Now, unfortunately, because of the growth of the problem, anywhere I go, anywhere in the country, in a group like this, I could ask, all right, how many of you know somebody or know of somebody who has an issue with prescription medications? And every hand goes up. 10 years ago, it was just a few. That's how widespread this has become. So how do we address this? Well, I can tell you that 46 people die every day in the United States. Horrible, but does that resonate with you? But when I can tell you it was 46, almost 47 in 2007 in Wilkes County, and that the overdose or the epidemic rate is 8, so that's 4 or 5, almost 6 times the epidemic rate that we were dealing with at that time. So we decided, all right, we've got to address it. We have to bring awareness because, again, I'm probably just as guilty as everybody else. We normally do not become engaged in solving a problem until what? We are personally affected. Well, guess what, folks? We're all personally affected with this. Somehow, some way. Whether it's our personal, our heart issue with somebody, or even our wallets because of the economic factor. So we realized our community's got to be addressing this. So how do we work with our different coalition groups? And that's where we started. You have a piece of paper in front of you. Project Lazarus Community Workshop. Why am I needed? What do I need to know? And what do I need to do? This is your worksheet. You can take it home. What do you personally need to know? Hopefully you will find out something today. And then what needs to be done. And I want you to look at this on the left column and the right column. You as a person, and then on the right column, what about you as an organization? What's needed as an organization? What do I need to know as an organization? And then what do you need to do as an organization? Because that helps you develop an action plan. And it could be as simple as, well, boy, I didn't realize the problem was this big, and I realize now that I better go home and look at my own medicine cabinet and get rid of what's in there that I don't need and make sure I lock up what I do need. That is an action that changes behavior, that reduces the risk of what medication you already had in that home from getting into somebody else's hands, or you being tempted to take it for something else. Well, why would I do that? Well, if you sprained your ankle 6 months ago, I'll reverse that. You went to a dentist 6 months ago, had hydrocodone because they pulled a tooth, and you didn't use it all, it was sitting in the cabinet, you sprained your ankle yesterday, and you said, well, I have pain meds at home, I can go take that. That is a non-medical use of a controlled substance. What happened to your body in those 6 months that brought about a change, that now that medication could be at risk to you, not realizing that? But our common behavior is, oh, I can save some money, it's right there. No, we can't. Again, those are some of the changes. So I want you to be thinking as we go through this today about answering some of those questions personally and then as an organization. Because this is what we're dealing with. We have a concept in the United States that we're pill happy. It's good for everything, and unfortunately there's a lot of good medicine out there that does a lot of good in individual lives, but unfortunately it affects lives adversely, within that context. Because the CDC shows us now that 55% of the diversion that's going on with medications is shared openly between family and friends. Another 15% is either bought or stolen between family and friends. So 70% of those 259 million prescriptions is openly in our communities being shared, bought, or stolen between family and friends. That means it's going on in the living rooms, the bathrooms, the bedrooms, the ball game, the school bus, the workplace. That's where it's happening. And that has to stop. But how do we stop that? You can't arrest our way out of that because we can't arrest everybody. We can't get in their living rooms. And there isn't enough manpower among our law enforcement agencies here in the county to do that anyway. So how do we change all of that? Because this is what we're dealing with. There is something for every ailment or every need that we possibly could have. Something to take me up, something to take me down, something to make me feel good, something to help me make me relax. So instead of using medication for healthcare, we have learned as a society we can take medication to what? Manage my lifestyle. So I hit that unfortunate proverbial brick wall, but I can take it to whatever I need it for. So I can keep going the fast and furious 100% of the time and have something to keep me going. So what does our data look like? And this slide here, and this slide, we'll send this to your email so that you can look at all these slides. This just tells you where we got the data from and what we're comparing it to across the state. All poisoning deaths in Wilkes County, and this is per 100,000, which is what the government uses to make everything comparable. There's a certain formula that we use. So this is every sort of substance that would have created a death. The black line is the state level, and the blue line is Wilkes County. And you can see in 2009 where we hit our high mark, unfortunately, but then we dropped off from there, and then in the past couple of years we've been seeing an increase in that. Now, part of that increase is a couple of explanations for that, because we're not where we were before, and I'll explain that. All prescription opioid overdose deaths. From the state level, you can see it's been trailing down for a number of years. Wilkes dropped, and then we've gone back up again. But one of the things that we have found, because remember, we look at the who, what, when, where, how, and why, because that provides us information. In 2009, we had patients, we had family members simply sharing, not doing anything that they thought was wrong. We don't have that happening anymore. The ones that we're seeing now are showing a history of substance use. And based on comments from Detective Dancy and Sheriff Shue and others in the newspaper, are the ones that are unfortunately overdosing, they have to go outside of Wilkes to get it. They can't get it in Wilkes anymore. They can't abuse the medical system. They can't abuse by going to the emergency department. They're going to other clinics and people in other counties and bringing it back here. Very difficult to stop, but if we get other counties doing that, guess what? We get everybody doing the right thing so that that doesn't occur. But then we have to find those individuals and make sure that we're reaching out, and helping them. Same with heroin overdoses. Unfortunately, in North Carolina, the past 2 years, it has been going up. And basically, on our count, we had basically one in the past 3 years of somebody dying that heroin wasn't an issue with that. We are not having the impact that other communities are having, but we have to understand that when we look at heroin, this is where it was in 2007 in North Carolina, darker counties, the higher overdoses. This is where we are in 2013. All right, it's become an issue. Why is it becoming an issue? Part of it is people going from opioids switching over to heroin. There is a percentage of that, not everywhere. One, a pill can cost you $25 to $50. A balloon of heroin, 10 to 12. And unfortunately, between the 18 and 25-year-olds, guess what? It is now socially acceptable to be using heroin. In my day, it was the worst of the worst, the dirty of the dirty, but now, unfortunately, among young people, it is, hey, it's cool. You can snort it, you can smoke it, you can inject it, and it's all okay. No, it's not okay, but that is the perception that's going on. Again, a public health perspective, how do we reverse that going forward? All emergency department visits, and I have to put in one little caveat to this. In the years between 2010, 2011, we had computer glitches between our hospital and the state system, so not all poisonings were registering correctly. So when you saw such a drop, we're not sure that that actually occurred so much. But understand, we watch this as quickly as we possibly can, because that tells us a really good story about what's happening in our community. Because for most people, any adverse event, where do they show up? In the emergency department. Then we can do a quicker intervention when we have that kind of information. And then hospitalizations from that, again, drop down, and then slowly, unfortunately, in the state and so forth, climbing back up. Everybody's, well, emergency departments and hospitalizations are going up. Is that bad? Not necessarily. Because we know that the more intervention we do, we're going to find more people reaching out to get help. And their common way of getting help is what? To show up in the emergency department. They might not have done that before. Now we've got more people doing that because they're realizing that many of our emergency departments are providing more help than they ever had before. But we still have to do more of that. So don't be aghast at numbers. You have to look at it in its entirety to make sure that we're interpreting it, correctly. But what about the spokes of this wheel? What about the spokes that the hub is driving? What about community education? If I've got mom sharing her meds with son Johnny, I have a problem. Do you realize that if you share a controlled substance medication, actually it is a Class B felony? Does the public know that? No, for the most part. Are they probably going to get arrested for that? Well, very hard to catch, but realize that is the extent of the law, regarding that. So we came up with a tagline, prescription medication. Take correctly, store securely, dispose properly, and never share. Trying to teach from a public health perspective what people do with medication. And I'm talking about medication. I use the word prescription medication. I do not use the word prescription drugs. When I grew up, it was medicine. Drugs were something else. When I grew up, I was instructed, medicine, if it is yours, you take it as it's prescribed. If it's not, you don't take it. That was my life growing up. So I never thought once of going into my parents' medicine cabinet. Never even dawned on me to do it. So I'm trying to divide that once again, but take correctly. Most people don't take correctly. What? They take it as needed. And that is the worst thing that a person in pain can do with medication. Because taking it as needed means what? If I have more pain, what do? Take more, okay? Oh, I feel pretty good today. I don't need as much. And then you double up tomorrow. You are going like this on that roller coaster, on that cliff of an overdose, just because of that. But again, most people don't realize that. And then, of course, store it securely. I've been in many homes, through hospice and home health and others, and you walk in and the kitchen counter is just littered with all the different prescriptions that somebody has. Old ones, new ones, all right there for anybody to take. And I will ask a question, well, I trust my kids. Do you trust the friends of your kids who are walking by, realizing that they might have a problem, or they realize that they could sell that pill for 25 to 50 bucks? We have senior citizens supplementing their Social Security by selling some of their medications to their grandkids in order to make some money. Now, did they learn that on their own? No. But again, everybody gets new information and a how-to and all of those factors going on. And then dispose of it properly? No way. I paid for it, I'm keeping it, and I might need it later. That is the attitude. But we can't do that anymore. We can't hoard the medication. And you know what? We who live in Wilkes, what do? We are a bunch of hoarders, let's admit it. Okay? We don't throw anything out. All right? We keep things because why? We might need it later. Or somebody else that we know might need it. We are nice people. And nice people do what? Well, if we're sitting here at this table, and one of you said, I really hurt my back putting in my garden the other day. Somebody else at the table goes, I have something at home that might help that. That's being nice, not realizing what happens. But that's where we are. So how do we change that? We talk it up with the individuals that we serve. Whether it's the 5-year-old in the kindergarten, or whether it's somebody who's in our organization that we have come in contact with. And then, of course, never share, we've addressed that. But here it is. Give it to me straight, Doc. How long do I have to ignore your advice? All right? That's, unfortunately, that's more truth than not. And the other side of that is, if two of us right now went into Wilkes Regional Medical Center, emergency department, and had to have a visit because of something that occurred, a sickness, an ailment, or an injury. And both of us went into the examining room and sat down with a practitioner and went through, well, this is what's wrong, this is what we found, this is the treatment, this is the medication. And both of us walked out at the same time. Both of us are going to have heard something entirely different. Now, how does that happen? That's our nature. Unfortunately, and I have to blame some of this on HIPAA and so forth, that no, I don't want any of my family members to know that this happened or that I'm taking this medication. When in fact somebody in the family should know, a caregiver should know, and be aware of the dangers and the risks and the benefits of the medication so that they can be aware to intervene. Those are all factors that we have to address. Good, bad, ugly, or indifferent, that's our makeup. Now, I raised them children, you were all once children. Can I go ask your parents, did you, 24/7, 100% of the time, do what they expected you to do? I haven't found anybody that can say, yes, I did. And I'd call them a liar anyway. But, the fact is, we can't change an individual even if we're living with them 24/7. So we determined Wilkes is our house. We need to fix it. What do? We change the village. Because the village can change people. Because once somebody's 5 years old, they are out of the house. They have a teacher, they have friends, they have peers, they have church, they have sports, they have all sorts of other individuals that are influencing them. As a 7th grader in Wilkes County, if they heard the message at home, if they heard it at school, if they heard it from their peers, if they heard it from their coaches, if they heard it from their clubs, if they heard it from their church, they might get the message that prescription medication, if it's yours, you take it as it's prescribed, and if it's not yours, you don't take it. We don't have to stand up and say don't do drugs. We're talking about behavior regarding medicine. Drugs we can talk about in another fashion, in another way, but this is how we can bring about that change, and that's what brings you part of it. Did this hit home with me? Yeah, one day. I was sitting with my younger brother, and I was one of 7. He's 6 years younger than I am, and I'm about to out him in his behavior as a teenager. I said I never thought once of going into my parents' medicine cabinet, our parents, when I was growing up. I mean, it wasn't a yes or a no. I never, ever thought of that. And my younger brother goes, but I did. And I said, you what? And he goes, yes, my sister and myself, we did. 5 or 6 years younger, same home, same family, same environment. They did what I never even thought once to do. They knew what was in there, they knew what it would do, and they went in and took it as teenagers. Thankfully, no adverse events or whatever else. I have yet to see my sister face to face. That will happen this fall. She is now a pharmacist. So, I'm going to be talking with her to find out what really occurred. But you know what happened? The village influenced them somehow, some way. And a negative. We can turn that around. So be thinking about where are you on that wheel and how do you reach somebody that you can touch to change them in all of those different aspects. We did that just to give you some quick updates. The chronic pain initiative that we started with Northwest Community Care Network here, that is now statewide with the community care networks of North Carolina. We're reaching the prescribing community. We created a toolkit for their prescribing, managing pain, and making appropriate assessments and referrals for treatment. All of those factors, it is statewide now. It is going to every prescriber that we can possibly reach or touch with that education so that they are doing best practice. Because they only got 9 hours of pain management education in medical school. So they need more, because they're the ones writing the prescriptions. We are helping out with that. And then, of course, we have the emergency department that we developed here in 2007, an administrative policy. I don't know if Kathy Kennedy here, but she was hired as the embedded case manager in the emergency department to work with those people that are frequently there. Because most people that are frequently there are there for the wrong reasons, and we need to get them into the right continuum of care. Policy said no more refills for controlled substance. If you are a frequent person for chronic pain, we're not going to give you a controlled substance. We will give you something else, but a referral to a pain specialist, a primary care physician, sign up for Medicaid, all of those factors. If it is warranted to write a prescription, we check the patient's history in the state database that we have now, and you're not going to get 30 days. You're going to get 10 to 12 tablets out of the emergency department. If you're there for the right reason, it's no problem. But if you're there for the wrong reason, guess what? You're not coming back. All right? Unless you decide, I do have a problem, and now we can get you into treatment and we can find you help. We want to make sure that we're not refusing care, but making sure it's the right appropriate care. Guess what? It worked. This is now, Novant has this in every emergency department in every hospital in the state. Vidant on the Eastern Shore, some of Carolinas. Everybody's adopting what we started here in Wilkes in 2007 because we realized it worked and did not deny anybody care, and it actually ended up saving money in the long run. But you as a community have to bring that together, because if somebody is there for the wrong reason, that emergency department or that prescriber better be able to share where that person can go for help. Because if a prescriber looks at that database and say, oh, we have a problem here, you're going to 3 other doctors for the same prescription, I'm not going to write this to you anymore, and I'm going to inform those other 3 doctors. Totally legal and can do that. What's that person doing the next day when they can't get their supply? If we can't help them, they are hitting the street, they are finding it somewhere else, and they are at risk for an overdose. We've got to have a warm handoff to the individual who's got the issue and not a cold shoulder. And only your community can do that. And we're doing that here much better than we ever had, before. And then we also have diversion control. Well, we're hoarding our medication. No, we're not. We're getting rid of it now, right? Where do we get rid of it? Well, we now have about 150 of those drop boxes throughout the entire state of North Carolina in our mostly law enforcement. There's one at the Sheriff's Office, there's one at North Wilkesboro Police Department, and now there's one at Brand New Pharmacy. Because as of October 9th of last year, the DEA made new regulations. Pharmacies can now take back controlled substances. They could not before. So now, when our local pharmacist can pass out a prescription, legitimate, to be dispensed, to be used, and maybe not all of it. They can tell the person, well, when you're done with this, you might need it all. You bring it back and you put it in that box. That will be a behavioral change. A behavioral change just like a seatbelt. Our cars did not used to have seatbelts. But now we get in and buckle up, most of us, without even thinking about it. Same thing, same premise. A public health change is what we're after. But it takes all of us to drive that. And we have to, you know, you have, I think we have some cards here for you to give you that information. We have church bulletin inserts that provide that information. The public needs to know about it. Not us. Us too, but they need to know about it. And that's how we can get, you know, kind of help that amount of medication, you know, that is in the community. We are supporting pain patients. People in pain need to know the risks and the benefits of their medication. They need to have exercise programs and health and wellness and nutrition and acupuncture and other avenues of how can they, you know, better treat their pain so that they can function. You know, when you have a cold, rainy day and you know somebody in chronic pain, what's the last thing they want to do? Get up and go out. Well, what's the best thing that they can do? Get up and go out. We've got to be able to be there for them. Develop exercise programs at local Ys and others so we can help support them in their chronic illness, their chronic pain. And then I learned about naloxone. And I'm sorry I'm going so quick, but I want to put you to work today. Okay? Naloxone. It is the antidote to an opioid overdose. Whether it's an opioid or whether it's heroin, somebody who was overdosing can have this medication and be rescued literally when they have actually stopped breathing. I learned about it in 2007. And I asked the question, who's got it? EMS and emergency department. Great. Guess what, folks? The ones who died in Wilkes County didn't make it that far. They were at home, in the bed, or in the chair. They didn't get the opportunity to do that. So I'm probably more in ignorance than anything else. I call up the president of the medical board and ask the question, if people are dying and this is available and you can't abuse it, why can't people have it in their homes? Thankfully, Dr. Ryan at that time said, guess what? That's a good question. Let's find out. So Dr. Albert, Sue, and I, and 3 others, we went down to the medical board and had a public hearing. They had their lawyer with their case. But guess what? After 45 minutes of talking, the people on the board, the doc, said, whoa, wait a minute. When you came in here, we were against this program. But you have convinced all of us that we are actually prescribing medication to patients in our own individual practices that are at risk of an overdose today. We connected the dots for them. They were the first medical board in the country to sanction and come out with a position statement saying, we support projects and programs like Project Lazarus, and naloxone should be available to anybody who's at risk for an overdose. That opened up the floodgates in the nation, folks, right out of here, right out of North Carolina, to do that. And I learned that, you know, it comes in various formats. And what it does, you have a brain receptor. All of us do. And I'll go through this a little bit more soon enough. Heroin for the H, methadone for the M, and opioid from, you know, pain relievers. And that's methadone for pain. The more that you have on your brain receptor, the more suppressed your breathing may become. To where your overdoses, you slowly stop breathing, you might snore and gasp a little bit, and then you fall asleep and die. It's not violent, it's not ugly. People in the same room didn't know that somebody died in the same room. They thought they were sleeping it off. Well, what happens when you have naloxone, it goes in and it kicks that receptor, that opioid off the receptor. And all of you, when you walked in here, what have you been doing? 2 things. Breathing and blinking. But you didn't think about it. The opioid on the brain receptor suppresses the breathing to where your brain is not telling your body to breathe anymore. This kicks it off and you immediately go, you breathe. You might not be comfortable because if you were using, you're in withdrawal. If you were in pain, you're back in pain. But what's the alternative? Death. At the time, it came in a couple of formats. Draw and inject. Now, I've never injected anybody today. Anybody want to step up and try that? I don't think so. So I'm a little uncomfortable with this. Long needle, draw and inject. Now, for a heroin-using population, it's not a problem. They're used to injecting. Then I found out that it came in another format, a pre-filled syringe, like this. And this is actually covered by Medicaid in North Carolina. You screw it into a plastic syringe, and you can either affix a needle or a nasal atomizer on this. And the nasal atomizer just screws on, and you can spray it into somebody's nose like this and get the same result as if they were injected. Save their life. You can give me 50 doses of this right now, and it would have no effect on me whatsoever. You can't abuse it, you can't overdose on it. If you need it, it's only because you have opioid or heroin in your system, and it kicks it off the brain receptor for 30 to 90 minutes. This is covered. This is separate. You put it together, and it's not approved by the FDA. Doesn't mean it can't be used, and in most cases it is, because it's not against the law, but it is not the FDA has not yet done, or completed, I should say, because it's being done now, a nasal atomizer spray of naloxone to see if its effectiveness. We just all know that it works. But then, we had this approved last year by the FDA. It's called Evzio, and this is an auto-injector for naloxone. And you don't need a DVD like ours does, or a booklet. It talks to us.
This trainer contains no needle or drug. To inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds. 5, 4, 3, 2, 1. Injection complete.
Life-saving. That's simple. It's prescribable. It's on the North Carolina Medicaid, CMS, and other insurances. And somebody can now get this for a $3 copay on Medicaid in North Carolina. This is the #1 on the formulary for the Department of Defense. It is now the #1 on the formulary for veterans. The Veterans Administration now has this on their mail home program, so that when somebody who's a vet is getting a 90-day supply of opioids, and guess who the #1 provider dispenser is for opioids in North Carolina? The Veterans Administration. They can now mail this home to the patient. They're not all doing that, but it's getting more and more, every single day. This is readily available. I can tell you right now, I have 500 of these sitting down at Brave Huey Pharmacy that I got donated. They got about 6 months left on their viability, but it's available to whoever might need it. So if you're interested or have somebody or know somebody that should have this, you just contact us and we can get it into their hands. And we're going to be supplying these to the health department. We're going to be supplying these to the opioid treatment program. It's available to the Wilkes County Sheriff's Office or any other law enforcement agency that wants to have this. It's available to our first responders and our fire folks. That is legal now in the state of North Carolina. If mom has son Johnny and Johnny has an issue, mom can be written a prescription for this by legal authority, even though it's for Johnny. So people want it, but they have to know about it in order to get it, and we want to work with you to make sure that it is readily available. Medical boards approved it, AMA's approved it, National Association of Drug Diversion Investigators, SAMHSA, ONDCP, ASAM, the American Society of Addiction Medicine. It goes on and on. 5 years ago, we couldn't talk about this at the federal level. Now the feds are promoting it. They've realized, what it can do and less harm. But what about treatment? Addiction treatment. Is it accepted? Is it available? And is it accessible? Where's Mr. Murphy? Do you remember the Child Abuse Prevention Team meeting conference that we had, 5 or 6 years ago? We mentioned one word and had a panel discussion about methadone as treatment for substance use disorder, disease of addiction. That was not a pleasant meeting. It was not in my town. I don't want those people, and you're doing a drug for a drug. Hopefully today I will sort of prove otherwise, but we have been able to reverse that in Wilkes County. Medication-assisted treatment has turned out to be scientifically proved, evidence-based, that it helps individuals who need treatment for substance use disorder, disease of addiction. Not everybody, but somebody. And you will hear me say this, and I've said it in Washington, there is not one treatment that works for everybody, but there is treatment that works for everybody. And if that treatment's not available, then we're missing our mark. And we're not helping everybody that needs it. Because not everybody's affected by an opioid. We know that, okay? You know the story, you know the movie. They walk into the poppy field and boom. But not everybody, okay? So we're all different, the biological aspect of that. But here is the perfect day. I hit a methamphetamine, I hit a heroin and some marijuana. Would that be a perfect day? Maybe for some, but why that? Methamphetamine. Well, let me back up a minute. Everybody in here, you've had food today, You've had water today. Both of that we provided to you. Do you know that you had dopamine today? We haven't provided that for you, but maybe we got you all stirred up and excited, and maybe it's at a higher level than what it was when you came in. But you needed 30 nanograms of dopamine to wake up this morning. Do you know what a hit of methamphetamine is? 1,100. Your body will never produce 1,100 nanograms at any time naturally. So an artificial use creates a rise in dopamine, which is what makes you feel good. That's what it's euphoric. That's what it's for. Now we're supposed to naturally be able to do that. Do you know your favorite food with your favorite people can raise your dopamine level to 94 nanograms? So can food be a problem? Sure. Can alcohol? Sure. Anything. Can exercise be? Absolutely. Because it raises the dopamine, endorphins, and makes you feel good. But understand, if you have 1,100 nanograms as a hit, what happens at the crash? Look at the graph. Amphetamine on the upper left, nicotine, cocaine, morphine. 1,100 nanograms instantly, and then you crash shortly thereafter. A person who has an addiction, substance use disorder issue, they are doing everything not to crash. Now, if you're talking about an individual, it's like, they're really high, they're really feeling good. Why do they keep using? Because they never ever want to go down that slope of the crash because of how horrible that feels and trying to live through that. So how does it become addicting? You got to keep having it. You got to keep having it, and the brain wants it. Cocaine lasts a little longer. Nicotine. Let me ask you this. As a teenager, what is the most frequent way? There's two primarily frequent ways that they would have an artificial substance raising their dopamine. What would those be? Alcohol and nicotine was an answer. I don't use so much alcohol, but it's true. I'm going to have to add that. Nicotine, because most teenagers try cigarettes at one time or another. Dentist. A teenager going to the dentist and having any kind of oral work done receives what? A pain reliever. Does the parent, or do you as a parent know what the response is going to be to that medication? You don't. When my son had his tonsils out, we were the firewall. Okay? There was no way that he was going to be taking that on his own. Because guess what? I can't stand pain medication. That's my biological makeup. Somebody else, they can take it for the first time and it can light them up. When I talked about it, the young lady, she was on 25 pills a day. And we were working with her. She was 15 years old, injured her shoulder playing volleyball in middle school, and she got on that medication, and I'm talking to her at the age of 29, taking 25 pills a day. It started when she was 15. Because it lit her up. It made her feel really good. Forget about the problems. Oh, I can cope better when I take this stuff. Because she had no other coping skills. But it helped her do that. So we have to realize that everybody has to be addressed somewhere along the line. It is the parent, yes. It is the dentist, yes. It is the convenience store that has all the cigarettes laying out there, or the candy cigarettes even, all of those factors, that we have to deal with. So understand what's going on in a person because of what they've taken. Cocaine, meth, alcohol, heroin, those are the brain scans. The ones with the red, those are your actual normal receptors that are firing in your brain. The longer somebody takes, those receptors stop firing. So when you think, well, substance use, somebody's abusing alcohol, somebody's abusing drugs, somebody's abusing medication, you're thinking, oh, it's a moral issue, it's a behavioral issue. Guess what? No. Their brain is telling them, I've got to have it, I've got to have it. Because of their use, their brain doesn't do it anymore, which is why they crash afterwards. So how do we bridge that between stopping on Monday and helping you on Tuesday? Because if we don't, guess what they're going to do on Tuesday? Go right back to what they were taking. You and I have the capacity to intervene with any individual at any age if we know the right avenue, for that. Brains on the upper left, the one that's potted, 40-year-old, 7 years on methadone, heroin use, 10 years. You can see what it does to the brain. Guess what? The brain can heal itself. That can be restored. Healthy brain, addiction brain, before and after. Some of those are from the Amen clinics up in Virginia. TROSA, which is a residential 18-month, 24-month facility for substance use over in Durham, North Carolina, did some studies. They did brain scans when people came in initially. 18 months, 2 years later, of no use, they did brain scans, and the brains were not yet fully back to their normal state. It takes time, and everybody's different. So our comments of, oh, just get over it, or just stop that and you'll be okay. No. There's so much more that has to be involved in that. This is our brain, and I'll go through it very quickly. The emotions and the pain, the satisfaction, the anger and the pleasure, the dopamine levels, and of course the regulation of pain. Guess what? They're all together in the brain. That's why when somebody takes pain medication, they can feel good, because it's on the same brain receptor. Opposite for me, I feel horrible, which I'm thankful for, actually. Then I know I don't have to have an issue with all of that. But if all of that is the brain and you artificially stir all that up, guess what? You can't just stop the artificial and expect the brain to redoing what it's supposed to do all the time. It takes time to do that. So again, that's why addiction now is listed, it's the disease of addiction. The DSM-5 now says, and the Affordable Care Act now says, it is to be treated like any other disease, whether it's a heart, lung, or something else. It should be treated and approached as a disease model and effectively treated that way. Some of it's going to take medication, some of it can take a 12-step and support. Everybody's different. But we have to make sure that it's all readily available. So lack of dopamine creates what? A craving. Put somebody in a survival mode and then a primal action. They do something to get it because the brain is saying what? Get it, get it, get it. And when you take somebody who's 25 pills a day, 45 pills a day, what were they doing 24/7? Anything they could to get their supply. Then what happens? Oh, well, I'm in treatment now. Oh, yeah, I'm getting methadone or buprenorphine, naltrexone. I'm doing better. But now they have 23 hours a day. What are they doing? We have done focus groups with those folks in treatment, and you know what? One of the number one things they tell us? Give me something to do. I have all this energy, I have all these thoughts, I have everything that I want to do, but I've got no means to do that. In Wilkes County, if somebody goes over to the detox center for their 5 or 6 or 7 days, and their body biologically is cleansed, everything else is the same way it was before, what is happening to them after detox? They're going into the same home, the same family, the same environment, the same community. If none of that has any support, they're going to fall right back into what they were doing. We have to change that. And we have to look at ways to do that. So the primal action, the diagnosis is based on a description of behavior. Then, of course, the aberrant behavior should be expected, and therefore behavior is a symptom, not a frustration. Did the behavior create the use? Maybe certain things, but the behavior that's occurring now, it happened because the brain has changed. Why is it that when somebody has gotten drunk, they have no inhibitions anymore? When somebody is on opiate use for a longer period of time, they have no concept of risk. It goes out the window and they do things that they would never do before because of that addiction. So, lack of dopamine is the basis that drives the behavior. The augmentation of dopamine then makes sense. If your body can't produce it, what can I give you to help produce it? And that's where your buprenorphine and methadone, your medication-assisted treatment comes in. Some people need that bridge to stabilize the brain. I don't know if anybody's here from a shelter or so forth, but if somebody showed up at your door today and say, hey, you know, I haven't had any money, I haven't eaten in 5 days. And you know enough to know that it was some of your behaviors, your lifestyle, and all of that. What's the first thing you have to do before you even have a conversation? Give them some food. Same thing. If their brain is not stabilized, I have to do something to stabilize the brain to even have a conversation to move anything forward in their life. Again, not true for everybody, but I'm making a point of this so we have to be acceptable of all avenues of science-based, treatment. Because we have genetic factors, we have cultural factors, we have environmental factors. Biological, we can do a lot with that on the front end. You can actually do genotyping now to see what somebody's metabolism rate is before you prescribe them something. That's now available. Not cheap, but it's available. But the cultural and environmental factors, that's where the community change comes in. If somebody got into treatment, got into the detox center, and they really don't want to go home because of what's going on at home, then we have a place to be able to give them to help them reestablish their lives. If we don't, we're missing it in any capacity. We as a community have to be able to respond to the need and not go like this because it's one of those people. We've got to change that attitude and that stigma. Addiction chooses somebody every single day. Nobody chooses addiction, but it happens. Adolescents who begin drinking by the age of 15 are 4 times more likely to develop alcohol dependence. Youth who begin drinking before age 15, 40% were classified as dependent later in life. Children who first smoked marijuana under the age of 14 are more than 5 times likely to abuse drugs as adults. Research demonstrates that illegal drug use among youth declines at the perception of risk and social disapproval increases. If there's that perception of risk and their social network, their peers are like, you don't do that stuff, guess what? They're more likely not to use. Can we make a difference with our young people in Wilkes County? Absolutely, if everybody's doing that. Whoever touches them, their coach, the soccer field, the ball game, their church, their youth group, their pastor, whomever, they can make the difference if they have the right message. Drug problem? Yeah, I hear it all the time. We have a drug problem. I'm not going to argue with that. Substance use problems have been around since day one. I'll even stretch this a little bit more because I am a chaplain. I can do this. What was the first item that was mind-altering in the beginning of time? Somebody ate some fruit in the garden, were they not? And did it alter the mind? All right? I just use that as an example. People can take and do different things and it alters their mind where it wouldn't do mine, but it might do theirs. We have to be aware, of those factors. But a drug problem. Are the drugs the problem? No. You got to go left of center. Biological issues, cultural issues, environmental issues, depression issues, trauma issues, poverty issues. They are all drivers to substance use. And we have to understand that. Depression, everybody knows how many, for years, Wilkes County has had what? Involuntary commitment issues here, high numbers. We still are high, but not as high as we once were. We did a study probably 3 years ago on why somebody was admitted to the emergency room and ended up in that status of at harm to themselves or another. Fully over 1/3, the primary diagnosis, the primary complaint was depression. If somebody is depressed, they will do whatever they can to get out of that, and most of the time it's going to be a substance use in order to do that. Why don't we start working on depression, the hopelessness, the poverty, the lack of jobs, all of those factors? That drives substance use. It's proven. Trauma. Trauma drives, I gotta cope, I gotta forget the pain. What's the quickest way to forget the pain? Take it. If you had a crack cocaine addict and they had $20 in an empty refrigerator, what are they gonna do? They're gonna go out and take a hit. Why? Because I can forget about it for however length of time that is. We've got to be able to touch all, and this is not all the areas, but we have to be able to touch, like circles of care, bringing people out of poverty, seeing generation after generation after generation in the same lifestyle, but they don't have hope. What about the individuals who have gotten into issues and had substance use disorder, have gotten into treatment, have gotten into recovery, yet they were fired from Lowe's or Tyson or the hospital or someplace else? Where are they going to go in Wilkes for a job? We can help do that. There is life with a second chance, a third chance, giving people the opportunity to excel and move forward, but we have to do that collectively with anybody who comes before us. That's our responsibility as a community. That's what makes the difference, to do that. Because the drug problem, what? Produces crime, death, economic factors, financial factors, family life crumbling, health factors, economics. I know we've been talking about our levels of young people who are moved into foster care. And unfortunately, we know that substance use is part of that driver. But guess what? That young person is now in trauma because they were removed from their parents. Are we addressing their trauma and debriefing it and counseling it and supporting their life to make sure that their coping mechanism doesn't turn to the substance that their parents were already doing? If we're not doing that, we're just keeping the cycle going and going and going. There are ways to stop this without saying, just get rid of the drugs. That's not going to change anything. Substance use was here at the beginning, and it's not just going to go away. But we can lessen it if the person, I don't need that. My life's okay. I've learned how to cope, and I've learned how to excel in life. So substance use disorder, you need the village to address it. Schools and everybody. And again, be thinking about the paper that's in front of you. What does your organization need to know, and then what can it do? So we started Lazarus Recovery Services. There's some brochures on your table around that. We have Devin, Lyle, Ray, and where's Daryl? Back in the back. These are individuals who will tell you that they are people in recovery. We have trained them, certified them at the state level, and they are now helping other people walk the road that they've walked. And we're paying them to do that. And I want to be able to pay more people to do that. Because guess what? When you know the walk and you've done the talk, you know exactly how to help somebody else. So when somebody presents in the emergency department, they were rescued out of an overdose. Are they going to be comfortable with the white coat standing over them telling them what to do? Or are they going to be comfortable with somebody who knows the walk and has done the talk, coming alongside them and said, listen, let me help you. Let's find you help. Let's find you a home. Let's find you treatment. Let's find you a job. And our people have already done that. Young man off of heroin. A husband got into treatment because his wife had already gotten into treatment. Because we intervened. That's what a community can do. We can't do it by ourselves. We don't intend to. We are not a be-all, end-all, but together, guess what? It's our house. You know, we can fix it. So Lazarus results, we know that we had a 69% drop from 2009 to 2011. That got the national attention because there was no other community in the United States that had that kind of a change. I'm sad to see some of our numbers going up again, but again, it's not the same factors that were there before. These are people that are going elsewhere and bringing it back, and we need to be able to reach them somehow in some way. Our schools. In 2011 and 12, we had 7.3 substance use incidences per 1,000 students. In 2012 and 13, 4.9, and in 2013-14, 3.4. We're gaining ground. We're not there yet, but things are beginning to work. Is that because we're in the schools and the schools are doing things better and different? Well, sure, that's part of it, but I guarantee you somebody at home is talking it up. Somebody at home is locking it up. Somebody's making a difference within the community to do that. Our diversion tips have increased. Our opiate treatment program that we did not have in 2010, Mountain House Solutions, now has over 400 clients who are in treatment, which means they're not using, they're for the most part hopefully not committing crimes, and they're turning their lives around. If that was not here today, those 400 people are Wilkes County residents who would be what? Using somewhere, going somewhere, creating problems. And I guarantee you more deaths. Well, when people began to have their lives changed, we actually had churches contacting us because they realized those people in treatment were in their church. We now have some of them financially supporting methadone and buprenorphine. From the worst of the worst saying that word methadone, we now have people paying for people to receive it in order to get the treatment that they need in order to overcome and recover from substance use. That is a shift. And that's been happening over the past 10 years. Are we there yet? No, but we've got work to do, but there is hope, but there has been some success. And I'm very thankful that Wilkes County has done that. And we're also down at Fort Bragg, and they were losing 15 soldiers out of 400. We were losing 46 out of 100,000. They were losing 15 out of 400. First year of Project Lazarus, it was 1 out of 400. Because changes were made on base, and now we've got other places doing that. Our prescribing levels did not have to change, so don't think we have to stop prescribing to make a difference. We can prescribe more wisely and maybe dose less, but there are ways that can be accomplished. And we have learned now with our statewide that those communities that have instituted what we've been doing here in Wilkes have a 23% lower emergency department visit rate for substance use issues based on coalition work. How many of you signed in or checked off your name when you came in here today? You all did. Guess what? You signed in, but you actually signed up. Okay? All right? So we've got work for you to do. So understand that. You're now part of the solution, and we no longer talk about the problem. We work on ways to get it done. And it takes all of us in every capacity. So this is our statewide. We now have, with the KP Reynolds Trust, they ponied up $1.3 million based on what happened here in Wilkes County. North Carolina Office of Rural Health said, we will match that, $2.6 million for the state. Project Lazarus and the Mountain Area Health Education Center over in Asheville, we got a federal grant for those 16 counties. So we had about $4 million over these past 2+ years to reach every community in North Carolina, and we walk in with the check. Here's $10,000 as your seed money for your community coalition to do what needs to be done to address this issue. And I just learned we might be able to up that to another $5,000 next year, on top of the 10 to start with, to build more sustainability. What have we done here? We just now got in Wilkes County, one of 14 counties in North Carolina, about $180,000 over the next 2 years for Project Lazarus to address 18 to 25-year-olds on this issue. Or no, 12 to 20, is it? 12 to 25. I should be reading my own. 12 to 25. And we have hired more people. Where's Kelly Huffman? Okay? She's been a case manager with another organization. She is now going to be working diligently in the schools. Dana Zacharias is here somewhere. She's been working in the schools. And we have another person from Western Youth Network who is going to be working in the schools with us. And our peer guides that are in recovery helping others, they will be working also, that we are implementing this for all Wilkes County schools up through the college, including the high school at the college over the next 2 years. Training for that grant starts on Monday. One of 14 counties chosen in North Carolina to get that, and we were able to apply and receive that. We have also applied for the Drug-Free Community Grant. That will give us $115,000 for year 1, 120 years 2 and 3, 125 for years 4 and 5. That is ages up to 18 that we will be working with and addressing. We don't have it yet. We applied, but we've made it through all the mustering up until the final review. But we won't know until October. That 115, we have to match that in kind and so forth. Guess what? We've been able to do that. Not with cash, but with work and volunteers and others. We only need to get from the community for that is about $12,000. And so therefore we double that with time and effort and so forth within our community, and that can be up for 10 years. That we can consistently work with our young people in the community. We will get that grant, hopefully this year, but I work with a lot of other communities, sometimes it takes 2, but ours was a very good application. So again, letting you know what we're attempting to do. So we have 2 possible grants now up to the age of 25. What about 26 onward? We need your help. We need your work. We need you to touch those individuals. We need to find housing and clothing and shelter and food and treatment and other things for the individuals so that, guess what? They can stay in Wilkes and live in Wilkes. We need a leader from every community sector as the coalition for Wilkes County to help implement and work with this in a greater capacity than what we've been doing. Because that, you work with your sector, you represent your sector, you can get your sector doing the things that it needs to do with the action plans that we're going to create today. The feds are now doing this prevention and intervention and treatment, and I need to move very, very quickly. But in doing that, it's a balance. We have to prevent, we have to intervene, and we have to treat. We have to do all of that across the board, and this is where we are in North Carolina now. 85 counties are implementing Project Lazarus today. When I say Project Lazarus, they are implementing what we did in Wilkes. Understand, Project Lazarus is Wilkes. It all happened here. It wasn't me, it was us. We met every Thursday morning once a month forever, and then every Thursday afternoon with the Substance Task Force forever in order to put this together. But understand, this has all still been going on, but there's still that much more to do. And now we're recruiting you to do, the more that's necessary. The lighter states are ones that have communities or entire states that are replicating what we're doing. I'm in West Virginia, I'm in Pennsylvania, all because people talk about Wilkes. I don't know if Jewel Hubbard's here, but he says, I can follow you because I Google search Wilkes, and every time that name comes up, it's where you are and what you're doing, because it's all attributed to what has happened here, Wilkes County. The federal government knows now, Congress knows all about Wilkes County and what this community did to reverse the horrendous condition that we were in. We still have work to do, but understand that coming together makes a huge difference. Project Lazarus is information on our website. You will be getting an email from SurveyMonkey from us. I want your opinions and your evaluation of what occurred here today. Very simple, check off, little comments and so forth. We want you to return those. I could have done hard copy today, but then we would have to enter 200 plus forms, and I don't want to do that, and I know nobody in the office wants to do that. So where do we go from here? You have forms in front of you. Got about half an hour, 40 minutes left, because I will steal about 10 or 15 minutes out of your time. Before we go any further, are any questions or comments about what's been shared before? But you're ready to go to work now, so I can shut up. Okay? This form right here is a national form that we out of Wilkes County helped create for every state in the United States to have a mapping plan on how to address prescription drug overdoses. This is a very global forum, and I understand that. It doesn't get into specifics. So what I did is I took it a step further, and I created this. The goal is the same. Achieve measurable reductions in controlled prescription drug misuse and abuse and overdose using a comprehensive approach. And then the bottom of your paper are what has to happen across every single community sector. Expand and strengthen key partnerships, secure and align resources and infrastructure, and use data and evaluation and research to inform intervention and continuous improvement. We are after continuous improvement. That's what we're after today. Well, what happens to that middle page? That's what I want you to be able to work on collectively at your table, or multiple tables if you want. And what you end up doing is putting in your community sector, and I'm just using the schools as an example. What do the schools need to do to expand and strengthen primary prevention? What do the schools need to do to improve monitoring and surveillance? What do the schools need to do to expand and strengthen control and enforcement? What do the schools need to do to increase utilization of treatment and support of recovery? When you begin to answer those questions, you have developed an action plan. And then we as a coalition want to be able to provide the means, the wherewithal, the materials, and the resources to help you carry that out. We can't do it for the schools. We can't do it for law enforcement. We can't do it for the hospital. They've got to do it themselves, but collectively we can help each other get it done. In what? Our own individual organizations. So I want you collectively to have this discussion at your table. Okay, pick a sector. If you're not sure what sector you're in, look at your label. Healthcare professionals. What can healthcare professionals do to expand and strengthen primary prevention? And then I want somebody at your table, give you about 15 minutes to do this, so you have to work quick. And please, do me one favor. I want a very clean, well-written copy from your table. Reason being, we will put this into a report and report back to you what each sector has determined what needs to be done. And then we will have a follow-up meeting to start initiating what needs to be done and putting force behind that. So discuss with yourself or mix with other tables and begin to answer these questions. There is no wrong answer. But think about it with what's been shared. Why am I needed? What do I need to do? What needs to be done? Thank you. 15 minutes.
Today we're with Fred Brayson II, the founder of the Lazarus Project, or Project Lazarus. Looks like it was a great success today, Fred, this community forum. You had a cross-section of nurses, educators, and healthcare professionals. To me it was a success, but what are your feelings about today?
Definitely a success. I mean, just to have that many people give of their time from a cross-section of the community, it makes a huge difference, because it's the cross-section, you bring them together, then you've mobilized, and that's what we were seeking to do.
And you gave them an opportunity to see one another, their different operations, and sharing.
Yeah, and in any community, from the smallest to the largest, I always find that not everybody knows what everybody's doing.
Exactly.
And this helps with that.
In your presentation, I learned something, and in fact, I learned a lot. And I want to thank you for letting us come here today and share with what you were participating in as far as the community.
My pleasure.
Okay, well, we want to thank you, and we'll be in touch.
All right, thank you very much.
Okay, today we were with a participant of Project Lazarus. Her name is Devin Wild. Devin, you want to tell us a little bit about how you got involved with Project Lazarus?
I do. I am a recovering addict myself, and I had went to treatment in Asheville, but I'm from Wilkesboro. I wanted to come back to my hometown to share my recovery journey with other people in recovery. I kind of felt a passion and a drive towards being able to help someone in areas where I felt like I may have needed help. So I am now working for Lazarus Recovery Services as a North Carolina Certified Peer Support Specialist. And so I just help link them back into society, help with housing, help be that, that warm hand that can guide them through the path to a more self-sufficient lifestyle.
That's right. You have a passion for it. You're very enthusiastic.
Yes.
As well. And you have to have been there to be able to share and to help other people. You just can't be going through the motions, so to speak. You can't
Right.
This isn't something learned. You have experienced.
And they do say that lived experience has, one addict's experience is most beneficial to another addict. That really helps in the recovery process.
Well, we're really pleased to be here and honored to be here and listen to Fred's presentation. We thank you for all of your help, and we continue support, and we want to get the community to support you emotionally and financially as well.
And we've got to, raise the awareness and break some of that stigma,
Right.
and be support, for these people that are trying to seek recovery.
And it affects communities. I learned that today in
As a whole.
presentation. Whether you want to be part of it or not, you are part of it if you live anywhere in any community or any state.
Yes.
Right. We want to thank you for
You're welcome.
sharing your time with us today. Bless you, and we'll be talking soon.
Thank you so much.
Okay, thank you.